Ladies and gentlemen, welcome to Gender Inequality in Health under Gender and Development Studies. We've done 2 or 3 of this. I think this is the 4th one that we're running into. So we continue on these discussions in gender inequality in health. Today, viewers would associate themselves with what is health, the explanation of it. Then what are vulnerability needs? There we'll be looking at focus on healthcare interventions as a basic right for every woman. We'll be looking at cost of interventions. We're looking at investments. We'll go to look at gender inequalities in terms of access, in terms of utilization. Then of course we'll be looking at its vulnerability in terms of rural and urban ladies. What are the other interventions? We'll be looking at Zambia, and then gender inequalities in health of Zambia, then gender inequalities of health in Ghana. To start with, health actually is just the absence of infirmity, that's illness, maybe in somatic, physical, and then you have to look at it in terms of emotional well-being, total well-being, psychologically, physically, psychologically, and mentally. So that is health generally, that you are in good health, you well-being, good well-being. That's what it is. It's not only about having a sore or having a running stomach. No, that's emotionally, if you're okay, that's fine. Psychologically, if you're all right, if you are in good well-being, that's fine. So that's what it is, health. It's interesting when we talk of gender inequalities in health, there is the tendency for us to observe and notice that it's been recorded, not just the tendency, but it's been recorded that women live longer than men after retirement. And in the US, about 5 years more, women live longer than men, 5 years more on the average. But the rest of the world, about 7 years more, women live longer than men. The eclectic nature of women's health is what is a bit quite, it's eclectic, so that's what it is. Women experience more years of disability than men. That's quite interesting and not too helpful, but well, that's what it is. It is what it is. And so we have to understand it. Once it's got to do with health, once we understand it, then we can turn ourselves around. Then the other bit is that women have some exclusive illness. That is what? Cervical cancer. That's exclusive to women. Then men have exclusive illness. That is what? Prostate cancer. And this too has to be looked at in its dimensions, proper dimensions. However, according to WHO, and that's UN SDG. SDG is Sustainable Development Goal 5. Everybody must be given equality in all sectors, in all levels, especially women and girls must be brought up to the level of equality in everything that we do globally. So then that's just an explanation of what SDG 5 stands for. That is for 2030. And if some countries are going to meet those SDG, especially the low-income countries, we look at it. Generally, when it comes to health and vulnerability itself, we look at women, the aged, and the disabled. They tend to be more vulnerable. So when it comes to gender, we're looking at the women, because we have established in previous discussions that because of the low-income nature of women, their needs are not mostly being attended to. Their needs of insubordination. Insubordination, that's the cultural aspect, has to be looked at, and we'll see it how it plays as it comes along. Then most of them are into domestic unpaid jobs, taking care of the family and all that. It's unpaid. And so do they have enough funding, cash, to access or utilize healthcare? That's another bit. So we're looking at vulnerabilities in terms of gender. It comes with thought. There are 2 women health needs, and under women health needs we have to focus on healthcare as a basic right. Then the other bit is the cost of interventions. Then the other aspect of vulnerable needs, there are 2. I said one is the women health need, the second one is gender inequalities in health. And so once we're looking at all this, we should be thinking quite clearly that if we look at the first bit, that is the first part of vulnerability, which is women health needs. Women health needs, one, I said we should focus on healthcare as a basic intervention, as a basic right rather. Um, yes, women and men must have equal access to healthcare, and that must be global. It must be universal, and then you must have access to it. It doesn't matter whether you're in the rural area or in the urban center. Everybody must have access to it, irrespective of the gender, and that is a must. It's a basic human right that we must give everybody. So each country, every country must ensure that all their citizens, especially women, are brought up. The gender discrimination, the gender inequality in terms of health is brought up to the point with legislation and implementation such that there is no difference. There's no discrimination against the health of women. We're looking at that. What about the cost of intervention, the cost of the health of women? That is where it's not discrimination, but the segregation comes up. Sometimes it could be discriminatory when we get to gender inequality. It could be discriminatory or it could be segregatory, in the sense that women, most of them, because they are not working, they don't have enough money. Domestic workers who take care of the family and all that, unpaid jobs as domestic work, they don't have enough money to cater for their health, to assess it and then utilize it. So they may be relying on orthodox medicine which may harm them without knowing the efficacy of those medications. That's one aspect. Then is it possible that countries can invest in health of women? Yes. Women hospitals must be set up such that it will bridge the gap between the men and the women. It will bring the women who are struggling to the parity with men in terms of health, where vulnerable women or poor women and girls are taken care of in those hospitals. That is one kind of investment. How will it be done? Is it going to be done through insurance? Are we going to go around the world or from country to country? Should countries adapt a policy where they issue a health insurance scheme, complete total health insurance, not partial? That will be taken care of by UN or WHO. They pay for it completely, or by the country requirements, maybe by the country resources. They pay for all the women, rural women, give them. They don't ask them to assess. They don't ask them to pay for an insurance, but the government pays for the insurance of all women and taking care of the exclusive health needs. I know men have got Men United against prostate cancer, but that can also be looked at such that there's parity. Okay, then if that is the case, with insurance, government giving all rural women insurance, it means that there is the difference between rural women health and then urban women health, and that we can discount. If that be the case, and which is the case, then it presupposes that we have to look at gender and inequality. Inequality in terms of access, and then inequality in terms of utilization. And when it comes to access, which is what WHO measures and UN also measures of health, access to health, women having access to health itself is problematic. It's problematic not because they don't want to access health, but there's a cultural connotation to it. The cultural connotation or traditional connotation is that women are subordinated in our societies. In patrilineal societies, patriarchal societies, women are subordinated. If they are subordinated, it presupposes, or it means that they would need permission from the husbands before, or the girls will need permission from their fathers. And it will mean that once they are taking permission to access healthcare, they need to be given money to access it. So to utilize it itself, you need money to utilize health. And the women, most women are not working, or women who are into domestic unpaid jobs need to be given money by their husbands or their fathers or their uncles or some male in a community that they know. And that is where the access itself is challenged, and bringing them, not bringing them, but leaving them behind the men in terms of accessibility to health, which has to be redressed. That's a cultural issue. There must be policies. Patriarchal nations must enact policies such that that aspect of subordination in terms of health, where women will have to seek approval and seek for money from men, must be abolished. That traditional practice must be abolished. It's consent. Partnership is consent, so we can discuss it and then they go. But they have their health insurance, which is taken care of by government, absolutely. Then they can just go and come back, and they are in good health. Don't forget, women, they take care of the family, so the children's well-being falls on them. They are the only person responsible for the rest of the family when the rest of the family falls ill. whilst we the men go out working and bringing the money home. Okay, so then that's one aspect. I know bringing the money home is not always the case, but that's generally that's what is expected of men to do. Okay, so it goes with access and then utilization. Utilization is got to do with the income. See, how does the income function in health? Utilization, how do you use the income in health? Do you use it for traditional medicine, or use it for orthodox medicine, or which is most suitable medicine, alternative medicine, which is the most suitable? Then you have to determine, has to be determined by the country health sector. You see, such that everybody must have access to utilize the health of that country. We go into rural and then urban. In our understanding of access and utilization, we have come to a certain agreement or understanding that rural women have poorer health than urban, or have lower access to health care than urban women. So it means that women health need, one of the most important and basic health need of women is what? Reproductive health. Reproduction and reproductive health. Their reproductive health is unique because men don't have that same opportunity to carry a belly and a child in the body. So then we have to put premium on what? Maternal health care. If that be the case, let's look in our countries. Zambia has a major problem with maternal health care, in the sense that Zambia is struggling, though they are improving. I have to be honest, they've improved so far. Zambia is a patrilineal or patriarchal society, so the access to healthcare is always problematic, and so it means women are also going to be struggling, and their maternal healthcare, utilization of healthcare is problem. The distance from one community to the health center is quite a journey for them, and then they having money to pay for healthcare is another. Besides, they need to take that money from their husbands or their male counterparts. Besides, there's this other bit, that is the intimate partner physically or violently assaulting women. That Zambia is improving upon, but it's a problem for Zambia, because once you assault them, you have assaulted their health. Yes, it's ill health. Okay, because they don't tend to be emotionally all right anymore, well-being anymore. Okay, we're looking at Ghana. In Ghana, the situation can sometimes be a bit unpleasant, but well, it has to be said for the Ghanaian authorities to look at. Pregnant women, generally, transportation is one problem. When they have to access health care, pregnant women in rural communities, some communities, they have to travel long distance, just like Zambia, travel long distance before they get to the health post. Some of them deliver midway the journey, or some may die, and some do really die. To that account, it's not proper. So it's for Ghana and Zambia to make the roads accessible. Communities must have community clinics where there is a what? There is a maternity home there. Perinatal deaths are something that you should avoid as much as possible. In Ghana, we have 1 in 54 women have a chance of dying when they are pregnant to giving birth. Whilst the world standard is that 1 in every 4,300 women have a chance of dying when they are pregnant. That's prenatal. But in Ghana, it's 1 out of every 54 women has the chance of dying due to complications in pregnancy and in delivery. It means that Ghana's situation is really bad. Really, really bad. Ghana has to look at it. Lack of information. We go to the rural communities and they lack information on pregnancy and stuff like that, maternal health care. They lack information once they need it. Besides the distance from their homes to the closest health care, it's quite a journey. They still lack information, and that information services must go to them, must send information to them, because I keep saying that it is public service and not public master. So you, the public servant, must send information to the women and the public on health. So mobile health services, which Ghana has, must go further and closer and make sure that maternal homes are closer to our rural folks. That way, we reduce the number of deaths from 1 to 54, heading to 1 to 3,000 or 4,000 deaths due to complications in pregnancy. Where we stand as a country is just bad in terms of Ghana. Okay. equipments for pregnant women are not just there. If they are, most women don't know, so it's information. But most health posts, we have to cite health posts in most communities closer to the people and make sure that they have a maternity home in there. And then they must go out, which they do, educate the women and have them brought into the clinic for prenatal care. The name is H. Kwame Afaglo. If you have any comment, please don't hesitate to send to the email address that you find at the close or the contact that you find at the end of this video. Thank you for watching.